Good evening, ladies and gentlemen. Welcome to First Aid AMC free sample question trial class. My name is Rabia Farid. I'm one of the tutors associated with First Aid AMC. I hope all of you are doing well. And if you can see the screen with welcome to First Aid AMC slide, just let me know. All righty. So I'm one of the tutors associated with First Aid AMC course. As you already had an introductory class and tips and tricks to solving sample questions with Dr. Arshan. I'm here today to go through what type of questions comes in AMC MCQ exam. So First Aid AMC course is a 5-month course, as you guys have already been made aware by Dr. Arshan. In this course, we not only covered the basic theoretical part of every system that comes into the AMC MCQ exam, we also practice questions to help you save time during the exam and to help you learn about the tips and tricks that you need to, that is highly helpful for you guys to get equipped with in order to help pass the exam. I'm also one of the ex-students of First Aid AMC, and I passed both part 1 and part 2 after attending course with Dr. Arshan for MCQ and clinical in my first attempt. So I have very good things to say about this course. It helps you get equipped with basic knowledge. Also, it gets you equipped with the right amount of knowledge required to pass the exam. And not only that, we also conduct tests on the software as well. You have lots of examinations there that you can practice to kind of judge yourself about the time management in the class and your knowledge as well. And most of the time, when you have theoretical classes during the week, me and one of the other tutors will take the sample question solvation classes. So we will also help you with the references about why the answer is right. And if you can't know the answer, we will help you with the tips about how to do the elimination process in selecting a correct answer as well. So let's start our class today. We will be doing, so these are the sources we use for the exam. John Murtagh is the main source that you use for your exam. It's a whole book with general practice medicine, pediatric portion, gynae and obs portion, general surgery portion in it. Then we have some guidelines associated with the Australian health system that is regularly practiced here. One of them is RACGP, which is basically related to questions that or the patients that a general practitioner sees in the clinic. Then you have RCH guidelines, or sometimes there is also, you can see QCH, Royal Children's Hospital in Melbourne and Queensland Children's Hospital. They also have guidelines about various diseases or presentations of clinical symptoms in the children as well. Then you can also see majority of the tutors using SA Health, South Australia Health guidelines. That includes basically obs and gynae cases. Health Direct for generalized knowledge. New South Wales, sorry, it's it's a typo mistake here. It's NSW instead of B. New South Wales guidelines, especially emergency medicine. Queensland Health Guideline, Victorian Health Guideline. Then we also sometimes use Kaplan and Med Bullets for sources like hematology, general surgery, or emergency medicine, and Med Bullets for hematology and orthopedic. Does anyone have any questions regarding this? So these are the journal sources we will use during our sample question solvation classes, and majority of the time your tutors will use John Murtagh as a reference, but these references are also used as well. So Dr. Arshan will be covering the theoretical part, whereas the other tutors will help you go through the question solvation. You don't need to buy John Murtagh, Dr. Galaya. In first aid AMC course, you will be provided with a soft copy of the latest edition of John Murtagh. And the other sources, you can just find it on the Google search. Let's go through that and start our class today, and I will help you guys know about what kind of question AMC usually asks in the exams and how do we solve it using the knowledge by these resources. So the first question is, a woman came with her 6-year-old girl shown in the picture and ask you when the said girl can return to school. So they're asking about exclusion, especially related to rash. After a week, tomorrow, now, after 5 days, after beginning antibiotic treatment. AMC is very focused on pediatric health and especially infectious diseases and pediatric health, especially with the rashes, which is associated with rashes. And they will ask you at least 3 or 5 questions related to it in the exam. They will give you a similar picture or something or some other rash picture and ask you about either treatment or isolation or further diagnosis. So can anyone tell me what the disease is? There is a erythematous generalized macular rash on the cheeks of this girl. So this is slap cheek syndrome. Can anyone tell me which virus caused slap cheek syndrome? Parvovirus, very good. So in parvovirus associated slap cheek syndrome, once the rash appears, the child is no longer infective. So you guys are absolutely right. The answer is the child can return to school now because they are no longer in the infectious period. This is RCH link I have shown here, and also a particular part from it. This is from the JM. Can a child go to school with slap cheek syndrome? Slap cheek syndrome is also called fifth disease. You don't need to keep your child off school if they have slap cheek syndrome, because once the rash appears, they are no longer infectious. If you suspect your child has slap cheek syndrome, take them to your general practitioner and let their school know once they are diagnosed with it. All right? So let's go through this guideline. Let me just share screen with you guys. All right. So this is RCH. Slap cheek is caused by human parvovirus B19. It's also called, it has different names as well. So sometimes they will give you infective agent within the exam question. Sometimes they will say fifth disease. Sometimes they will give you parvovirus B19, or sometimes they will say erythema infectiosum. So you need to be familiar with all types of name they have given to slap cheek syndrome. Most of the children don't have symptoms, but those that have symptoms, they occur between 4 to 14 days after the child has been exposed to the virus. They have prodromal symptoms of fever, headaches, stomach upsets, aches and pains. After a few days of being unwell, they have a bright red macular rash that appears on the cheeks. They can also have the rash on chest, back, arms, and legs that look like a reticular pattern. And after some time, several weeks or months, the rash can disappear or the rash can desquamate as well. It can spread in the first few days before the rash appear by respiratory droplet pathway. And once the fever has resolved, number one, or the rash appear, the child is no longer infectious. It's a viral infection, so we know we can't give any antibiotics. So we just give symptomatic treatment to the patient, make them comfortable with paracetamol and ibuprofen. And when we see that the patient is not improving, then we seek help. When to see your doctor? If the rash is not disappearing when you press it, which is the non-blanching rash, if you have a maculopapular rash, that is red spots or purple spots or unexplained bruises, and a very high-grade fever within an irritable child, then you might suspect it can be a meningococcal infection. Or if your child is immunocompromised, then you need to seek help from the doctor. Clear, guys? Do you have any questions here? So that is how we discuss our sample question solvation classes. We go through how we have selected the right answer. We give reference for how we have selected the right answer. And if sometimes we can't find the reference, we help you guys learn about the exclusion method. So know about each of the option you have in your question. You should be aware of what is the rationale behind choosing a correct answer as well. And we try to get you guys so much equipped with the knowledge that you take like 1 to 2 minutes in solving the question. All right, let's move on to the other question. A woman came with her 18-month-old child, anxious about yellow-colored fluid surrounding the meatus, and the foreskin is partially retractable. What is your next step as the doctor? Do the circumcision, give betamethasone cream, give mupirocin cream, give oral phenylmethylpenicillin, which is an antibiotic, or give IV benzathine penicillin. So here, it's a very small child. Look at the age group, and they're coming with penile problems, yellow fluid surrounding the meatus, and partially retractable foreskin. So that makes you think about either inflammation or infection. There is no fever, so you will not be thinking about infection here, right? And if there was no signs of infection or inflammation like erythema, swelling surrounding the area, pain, then less likely to be an infection. So very good, Dr. Yotin and Dr. Sapphire. The answer is that this patient is suffering from balanitis, which is inflammation of the foreskin leading to seepage of yellow fluid in the area. Whenever a patient of this young age has balanitis, we don't usually recommend antibiotics in the kids unless the condition is expanding or cellulitis is happening, right? So let's look at the, so answer here is we give the steroid cream. Let me show you guys RCH guideline. All right. So, all righty. So they have all the conditions related to the penile area and the foreskin in this guideline from the RCH. So it's quite comprehensive as well. It's very similar to how it's presented at JM as well. John Murtagh has similar, very summarized version of penile and foreskin problem in pediatric age group in a table as well. So what you need to do, a non-retractable foreskin is not a red flag. It's a normal variant and doesn't require intervention. It should never be forcefully retracted for cleaning. Acute surgical interventions is rarely required, but if there is red flags, again, very important to remember if you're choosing an answer, because if the red flags are present, your answer will drastically differ from what we have chosen. So if the child is suffering from urinary retention, if there is a swollen red penile area, or patient has fever and blue/black distal penis, then these are the urgent intervention red flags. So balanitis is the inflammation, minor redness and soreness of the tip of the foreskin, and it can be managed with just reassurance or avoidance of the chemical/physical triggers. Chemical triggers could be the urine, soil nappies, soap residue, physical trauma, can be forcible retraction, and very commonly nappy rash. So treatment is that you clean the area with just salt water. Barrier cream can be used, which is pseudo cream or zinc cream, or you can just use 1% hydrocortisone cream. It is also very useful in nappy rash as well. It just helps with reducing the inflammation in the surrounding area. If you suspect that the child has a fungal infection, for example, child has white areas or nappy rash, you can recommend an antifungal cream as well. You can give paracetamol or ibuprofen to keep the child comfortable. Topical antibiotics and ointments are not recommended. Clear, guys? But if there are signs of infection, for example, child is febrile, you should do a urine examination to exclude that it might be a UTI. And you should do a swab as well to make sure that there isn't a infection going on within the skin, because this is an area where streptococcus lives in our skin, and when there is a disruption in the skin barrier, it can go inside and cause infection, and patient will have cellulitic appearance of the penile area, and it is quite uncomfortable for the kids, and they might present with fever as well. So for that, we should do oral antibiotics, which is the antibiotic of choices. As we know, it is a Streptococcus pyogenes. We should use penicillin, flucloxacillin, or you can use cefalexin as well. You can give paracetamol and ibuprofen to keep the patient comfortable, and soaking in warm salt water and other things are also helpful. Similarly, there are other conditions of the penile area: phimosis, paraphimosis, zipper injuries, hair tourniquet, circumcision, post-circumcision problems, priapism. These are all given over here. So if you want to have a read, it's a good source to read. Any question, guys? All righty. Link is given over here, Dr. Sulaf. So if you just write in RCH, you can get associated with that. Nappy rash is a rash that appears in the perianal area when there is when a child remains in the soiled nappy or there's disruption of the skin barrier. You can use for example, like a barrier cream to prevent that. But if you think there are signs of fungal infection in there with white patches coming on the perianal area, you can also prescribe an antifungal cream for the patient as well. Pseudo cream and 1% hydrocortisone cream, both are useful as a barrier creams for nappy rash treatment as well. Yes. Are you clear, guys? Any question from you? So this is how we discuss questions. And if you have questions, you can just write in the chat and I'll be able to help you guys with the try to clear your concepts. Even during our sample question solvation class, we interact in the similar manner. We discourage people to talk on the microphone because it's very difficult for the other people to understand as well. But just writing in the chat box will help other people understand about different perspectives of looking at the question. So this is how we discuss in the class as well. And sometimes there are at the end of the class, if our students are struggling with any sort of topic, we also try to help them with that. Or if they have any different questions they acquire from somebody and they have some concerns regarding that, we also try to help them with that as well. The answer of previous question was now. We isolate once the rash has appeared, and in this question, answer is betamethasone cream. Betamethasone cream. Alrighty. Let's move on to the next question. Parents came with the 4-year-old child having breathlessness and palpitation. Okay, we have a question. Can we reassure in this? We can, Dr. Anil. If they have given you option about reassuring and maintaining hygiene, please, because this is the first step we do in balanitis, we reassure the parents. But if they haven't given you an answer similar to this one in your question, then try to go with the best answer in there. Let's focus on the next question. There is a 4-year-old child who is brought to emergency department by his parents. He is breathless and he's complaining of palpitation. We did an ECG. What is your next best step? So sometimes, just give me 1 second, Dr. Sapphire. I'll share the ECG with you guys. So sometimes they will use these words, which are very common in AMC, MCQ exam. What is the next best step? So when they are asking you about next best step, they are asking you about the best thing that you can do that can save this person, right? So if they ask next step, then the next step, for example, if this person was hemodynamically unstable, what would be your next step? Next step would be to maintain airway, breathing, circulation, right? But they're asking next best step. When they say next best step, they are not necessarily emphasizing about the next step of management. They're asking you about the management that will save this person. So let me share with you the ECG of this question, and then we can come back to our options again. So this is the ECG of the 4-year-old child. Can anyone tell me what this ECG pertains? He is having palpitations and breathlessness. So we have done an ECG. ECG shows it's a regular rate narrowed QRS complexes with no P wave, or the P wave I can see superimposed on the T complexes. So this is supraventricular tachycardia. Very good. This is supraventricular tachycardia. Now we'll go back to the question. We have established that this child is suffering from supraventricular tachycardia and is symptomatic with it. So what will you do next best step? Reassure them that this is a sinus tachycardia. Put cold water on his face. IV adenosine to terminate the episode. IV lignocaine or IV beta blocker. Again, emphasizing on the age of the child. 4 years of age. Next best step. Supraventricular tachycardia. Very good. So we are having different answers. We are having answer C and answer B. Majority of supraventricular tachycardias can be managed with Valsalva maneuvers. Very good. So putting cold water on his face, majority of the time, at least 80% of the time, it reverts the tachycardia or arrhythmia. If Valsalva maneuver fails, then what do? We give IV adenosine. Clear, guys? So next best step in management is you put cold water on the face or immerse their whole face in cold water. Is it clear? If they said, for example, parents came with their 4-year-old child having breathlessness and palpitation with ECG of SVT, you tried Valsalva maneuver but with no effect. What is the next best step? Then what would be your answer? Very good. Then you would choose adenosine because 80% of the time, supraventricular tachycardias get reverted with just Valsalva maneuvers. If they don't get reverted, then you can go towards the adenosine. But most of the time, because we are disconnecting increasing the vagal tone and decreasing the AV node conduction by Valsalva maneuvers, we can physically terminate the tachycardias or revert the tachycardias. So B is the answer. If you look at this, let me just reduce the size of the screen a bit. If you look at this is taken from Emergency Management of Supraventricular Tachycardia from Heart Association of Australia. Doesn't matter what sort of age it is for supraventricular tachycardias. In pediatric population and in adult population, we do the same. So you attempt to identify the cause of the supraventricular cardia, but you don't delay treatment. So first thing that you do is you give emergency treatment, which is vagal maneuvers. Vagal maneuvers will always be given when the child is hemodynamically stable, meaning their blood pressure is fine, they don't have altered level of consciousness, their heart rate is okay as well. Mr. Samsung, I would advise you to please close your whiteboard because it's causing marks on my screen. If you could do that, it will be very helpful. Thank you so much. Alrighty. So there are different things that I want you to remember as well. Whenever we are treating any tachycardias, we are concerned about hemodynamic stability or instability as well. Hemodynamic stability depends on your blood pressure, your heart rate, and your level of consciousness as well. If all these are stable, then you can do vagal maneuvers. If your blood pressure is not okay, if the child is having altered level of consciousness, then it's a sign that you need to give them shock. You need to, because if a child is or an adult is presenting with hemodynamic instability, that is a sign that this arrhythmia is causing problems with perfusion now. So that requires urgent management. Vagal maneuvers take time, but urgent management in case of hemodynamic instability is synchronized cardioversion. All right, you have done this and the child is stable, but it's not reverted, then you can establish an intravenous access or intraosseous access and give them adenosine. If the child is unstable, which is hypotensive, decreased level of consciousness, shock or chest pain, then you do the synchronized cardioversion. And you see the rhythm again, assess the rhythm again. If it's not stable, you do the shock again. Clear, guys? Any question from anyone regarding this? Yes, there are certain contraindications for vagal maneuvers as well. Very small children, which are less than 2 years of age, and very frail adults, more than 80 years of age, we don't do vagal maneuvers in them. Because in those conditions, in very small child, the cardiac system is not established to respond to vagal maneuver. And in very elderly person, most of the carotids are stenosed. So if we do vagal maneuvers by doing carotid massage, we can basically dislodge a clot in there. But we can definitely immerse their head inside the water. All right, Google and Dr. Kulsum Zain, which part do you want me to explain? So in any arrhythmias, doesn't matter whether it's atrial fibrillation, supraventricular tachycardias, ventricular tachycardias, we always see, first of all, whether a person is hemodynamically stable or not. Hemodynamically stable means that their blood pressure is okay, they don't have altered level of consciousness, they're not complaining of chest pain, and they're not in condition of shock. If everything is okay hemodynamically, then you can try to do maneuvers. For example, in supraventricular tachycardia, you do vagal maneuvers. But if the person is hemodynamically unstable, especially in supraventricular tachycardia and atrial fibrillation, you do synchronized cardioversion. Whereas in ventricular tachycardia, where you don't have a pulse or ventricular fibrillation, you defibrillate the person if they are hemodynamically unstable. Is that clear? If the maneuvers are not working, then you can move on to the adenosine. And if adenosine is not working, you can consider another antiarrhythmic drugs like procainamide, amiodarone, which is sodium channel blocker and potassium channel blocker. Alrighty. Clear, guys? Alrighty. Let's move on. It's in all, if you want to study all of the arrhythmias, always make an algorithm. Make two situations because they will always ask you about two situations. One is where the with the person is hemodynamically stable, and one is where they are unstable. Then you can always remember the answer, what you need to do in which situation. Even when you are practicing medicine, then it's also very easy. The first thing to assess in a patient who's coming with arrhythmias is airway breathing circulation. We don't use calcium channel blocker in supraventricular tachycardia. It's contraindicated most of the time. We use sodium channel blocker or potassium channel blocker. It's not recommended in supraventricular tachycardias. Alrighty. Okay, next question is Yasmin. It is the name of oral contraceptive pill in Australia. It contains drospirenone, which is type of progesterone, and ethinyl estradiol. It's now released for usage in Australia. What makes it to be preferred by women? It causes weight loss rather than weight gain. It has good effect on acne. It causes less spotting even at the very beginning of the treatment. It has a failure rate less than other OCPs. It has protective effect against cervical cancer. Alrighty. So this is a tricky question because it's most of the patients, most of us doesn't work with oral contraceptives very often. So there is a way of knowing of trying to go towards the right answer. So look at the formulation first. It has drospirenone and ethinyl estradiol. Ethinyl estradiol is normal estrogen, but drospirenone is the type of progesterone that has anti-androgenic effects. Anti-androgenic effects mean that it doesn't cause weight gain, it doesn't cause acne. All right, there are two anti-androgenic effects of drospirenone, and it doesn't cause fluid retention. Let's go from down to up. It has protective effect against cervical cancer. Oral contraceptive pills do not have protective effect against cervical cancer. They increase the risk of cervical cancer and decreases the risk of endometrial cancer, ovarian cancer, and colorectal cancer. So OCPs decreases the endometrial cancer risk about 30%. Ovarian cancer about its protective effect is about 15%, and endometrial cancer, let me just write it down, 30%. Ovarian cancer about 15%, and colorectal cancer about 15 to 20%. So it has protective effect against this, but it increases the risk of breast cancer and cervical cancer. So it doesn't have a protective risk against it, right? So this is not a correct option. So this is out, right? It has a failure rate less than OCPs. No, it has same failure rate as other OCPs. It is not superior to other OCPs because of its less amount of its failure rate. So it's wrong, same failure rate. It causes less spotting even at the beginning of the treatment. OCPs can cause amenorrhea and can cause less spotting. Doesn't matter which preparation is used. So we have two of these left, right? So which option to choose best? Your JM states that Yasmin is used or preferred because what's very good for women? Can anyone tell me? Would we prefer it for acne or would we prefer it for weight gain? Because OCPs is notorious for weight gain, right? So it's very commonly used and preferred by women because it causes weight loss rather than weight gain. And especially in patients who have acne problem, they have a benefit as well, but it's mostly preferred because it doesn't cause weight gain. It doesn't cause fluid retention. Is it clear, guys? So this is written in your GM as well. In chapter contraception. All right. So you guys can have a look at that as well. I have given a link over here, which is NCBI. So you can go through this, which will give you some generalized information, but this particular line about why it's preferred over other contraceptives is written in JM. So you guys can have a look through that. Clear, guys? Any questions? Dr. Zoom, you will be provided the recording of that. You can have a look through the questions when you're given the recording on the Facebook. But now we have a limitation of time, so I can't go through the previous questions again. I'm sorry about that. Alrighty, now we have moved on to the gynae section of our presentation. A 20-year-old primary, very important, young and primary gravida, is in labor and at term. She told you she wants no interference in labor process, whether it's medical or surgical. She was 3 centimeter dilated, head was at 0 station. After 4 hours when you assessed again, she is 9 centimeter dilated, head is at +1 station. She is doing okay. You gave her some analgesia. Computography is normal. What is the best next step to be done? Would you do a cesarean section? Would you do a ventouse pump delivery? Would you re-examine her in an hour or so? Would you give oxytocin to move things along? Or would you do an episiotomy at this stage? Now, this question is very much related about the progress of labor and complications assessment associated with it. They have given you, it's a young patient, first time pregnant, coming to you at term. She told you she have already made her wishes very clear, and we respect our patients' wishes as much as possible, given that we explain about the situation of life and death to them. So she has explained that I don't want any intervention. When you examined her for the first time, she was 3 centimeter dilated, head was a 0 station. After 4 hours, she made good progress, about 9 centimeter dilated now, and head is +1. So she is having a good partial Bishop score. Even though the Bishop score, they haven't given completely over that, you can still see after 4 hours, she is progressing in her labor with the cervical dilatation and the position of the head as well. She is doing okay at this time, and you have also given analgesia. The baby monitoring is absolutely normal. So there is no red flag given. What will you do in this situation? You will just re-examine her again. So the correct answer is C. She said she doesn't want any medical and surgical intervention. So no to cesarean and no to oxytocin drip. Do we do episiotomy when the head is at station 1, or we do the episiotomy when it's crowning? So we do episiotomy to facilitate with the head birth when the head is crowning but is having difficult time to come out of the introitus area. So we do episiotomy at that time. When the head is at station 1, there is no point and no evidence that this is an indication to do episiotomy to facilitate with the birth of the head. So The correct answer is because she's progressing quite well and she made her wishes known that she doesn't want any intervention at this time. And there is no need for intervention as well because her labor is progressing quite normally. So we will just re-examine her in 2 hours. Does that make sense, guys? Give oxytocin drip. She has made her wish is quite clear. She doesn't want medical or surgical intervention. If she is progressing normally, then we will respect her wishes and we will try to make sure that the labor progress as much normally as possible without any without any detrimental effect to the fetus and the mother as well. Is it clear? Any question, anybody? All right. So the answer is re-examine. What if there wasn't any patient wishes? You will still do the same. There is no need to do any intervention. There is no need to do any intervention. Why do you want to start her? I know everybody's thinking we should start her on oxytocin. Why? What is the indication? Why do we start oxytocin? Can anyone tell me why do we need oxytocin? Even if there was no augment contraction, right? But she's progressing, she's almost 9 centimeter after 4 hours. She made tremendous progress within 4 hours. Would you still recommend for her to go to 1 centimeter progress with oxytocin? No, we would not. It will be highly unethical and unprofessional for us to give oxytocin just to make sure she dilates 1 centimeter quickly. It's not good practice to augment contraction when she's progressed tremendously in 4 hours to 9 centimeter. There is no indication of augmenting. If there was no process, yes, I agree with Dr. Jalea. If there was no progress even after 2 hours, then certainly you can have a chat to her about augmentation of the labor if she's not progressing well. If the patient's condition is strongly indicated for oxytocin, but she refuses, what will you do? You will try your best to educate her, but if she doesn't want any intervention, you can't give. You can't give intervention. In Australia, patients' autonomies and their preferences are respectable. If they said no to a treatment and they have capacity to refuse, then you cannot force a treatment on them. So I have given just a table for you guys to just have a go through about the mean duration of various phases and stages of the labor. So in nulliparous women or primigravidas, the latent phase is 6.5 hours with the upper limit being 20 hours. Active phase is 4.5 hours with upper limit being 12 hours. Maximum dilatation per hour should be 3 centimeter or 1 centimeter. And second stage should be 1 hours to 3 hours. It's quite different in multiparous. Things are already, multiparous uterus is already aware about how to birth. So it takes less amount of time as compared to nulliparous women. Clear, guys? Any questions? All right. Let's move on to our next question. Now, I have given this question here just to give you guys an idea how situation changes and how red flags changes your answer. So there's a 32, a bit older primary gravida who came at 28 weeks. So this is how much trimester this is? I think this is second trimester, no? Yes. Second trimester, and she is complaining of contraction. So she is in preterm labor. Her examination 3 weeks ago was pretty normal. So, and the baby's examination, meaning the fetal heart sound, was also normal. You do a CTG. You did a CTG when she came 3 weeks ago. Everything was normal. What is the best test to be done to reveal the problem of the baby and give a clue about early intervention to save it? Fetal blood sampling, mother serum for Ig anti-D titration, beta HCG, ultrasound, or amniocentesis? What is the best test? They haven't asked you about the next step. They have asked you about the best test to give an answer about what is going on with the baby. Very good, Dr. Wendy and Dr. Param and Dr. Kokila and Dr. Sahra. So the best test that will give us clue about whether baby is in distress or not is fetal blood sampling. All right. Fetal blood sampling give us clue about acidosis. And if acidosis is high or lactate is high in fetal blood, that indicates that the fetus is suffering from hypoxia. Amniocentesis is not generally the term used because fetal blood sampling is more appropriate. Amniocentesis is the test we use to detect chromosomal abnormality within the fetus, not to help us predict about the preterm chances of the labor. And ultrasound is the next step we do whenever we think that there is something wrong with the baby. So if they said, what is the next test to be done to reveal problem of the baby? Then absolutely you will do a non-invasive ultrasonography. They're asking you about the best test to be done. Look how the wording changes the answer of the question. So they're asking you about the best test that will give you information about whether the fetus is having whether the fetus is in distress or not. Is it clear, guys? And amniocentesis most of the time is done in the 15 to 20 weeks of pregnancy. And they are performed in a woman we think that have risk of congenital defects in the baby, birth defect. All right, like genetic problems. It's not done to detect about problem with the baby and clue about early intervention to save it. It doesn't show anything about that. So fetal blood sampling will help you to prioritize whether this baby needs to come out now or this baby needs some more time in utero to recover, or what is it you can do within the mother or risk stratification within the mother to make sure that the baby has some more time. All right. Amniocentesis is not done for that. Amniocentesis is basically genetic problems detection step. And ultrasound should be the next step, not the best step. Okay. Clear, guys? So your answer is fetal blood sampling. Oh, I didn't show you the CTG. Oh, there was a CTG. Sorry about that. There was a CTG given with this question as well. Sorry, I didn't see the next slide. This CTG was the one done in this mother who came to you with contractions. When they did a CTG, it was this CTG. So if you look over here, these are the uterine contractions, and these are the heart rate of the baby. If you see how the uterine contractions and the heart rate are differing in dooms, when they are differing in dooms, then it means that the bump is having late deceleration, which is associated with decreased uterine blood flow and can occur as a result of hypoxia, placental abruption, cord compression, excessive uterine activity, maternal hypotension, and hypovolemia. Yes, they will give you CTGs with the actual MCQ question as well. No, we can't do amniocentesis to detect any abnormalities in CTG. It doesn't give you any information. So what we will do fetal blood sampling when we know there is late decelerations going on in this CTG. Let me show you guys. So SA Health for anything related to obstetrics. Let me just open up. So this is how it looks like. Antenatal indications for monitoring. This is how they talk about CTG, so baseline fetal heart rate, baseline variability, sinusoidal ECG, CTG, accelerations, decelerations, types of deceleration, which is early, variable, and late deceleration, complicated deceleration. Late deceleration is that you have repetitive decreasing heart rate with slow onset in the mid of the contraction, just like in our CTG. So the doom of the contraction is opposite to the heart rate of the, so it's like opposite pyramids against each other. All right. So this was the late CTG, and late decelerations in the CTG is classified as a red or abnormal CTG. Yes, you do have to learn all these patterns, otherwise you won't be able to identify the CTGs. Now, what to do when the CTGs are normal, abnormal? So first of all, when a mother is coming to you with all of these pattern, this is SA Health, Dr. Patel. So when a mother is coming to you in a preterm or any part of their gestation with any problems, the first thing that you do is the cardiotocography, or you can do ultrasound as well. This is fetal surveillance, basically. It helps to rule out problems with the mother's contraction and help us to get a good idea about what the heart rate of the baby is doing with the contractions. It will help a lot. CTG, we know how to perform. Let me just open up what we do in the normal CTG. You don't need to do anything. Fetal compromise is in late decelerations. As I talked about, it causes hypoxia, it can be cord prolapse, it can be uterine activity or placental problems. So what is the next best step that you do when you know there is an abnormal CTG, like in our one? We try to make sure that mom is having adequate oxygenation, and then we do fetal blood sampling. It just gives us information about fetal lactate analysis to determine the presence of the acidemia. Then we can escalate to our obstetric consultants, and they can decide whether this baby needs to come out or whether this baby needs or mother risk stratification can be done to make sure that the baby stays in vitro for a long time, and then they can try to reverse this as well. But the only way after CTG, the way you can assess that the fetus is having problem is fetal blood sampling. Is it clear, guys? All righty. We'll move on to the next question. Another obstetric question. A 34-year-old primary gravida came at term with ruptured membranes and meconium-stained liquor. You did a CTG. In review of the CTG, what is your next best step? Next best again means the step that can help to save life. So let me show you guys the CTG. Again, same CTG. Doom with the contraction is away. So this is a late deceleration. It's a red flag CTG. And what else is giving you indication that this the child or the fetus is in distress. What else? Other than the CTG, what else is indication? Meconium. Very good, Dr. Maria. So meconium is baby's poo basically. If there is presence of meconium within the liquor, it means that the baby is in distress. It's a sign of fetal distress. And the CTG indicates, sorry, I keep saying it ECG. The CTG indicates that it's a late deceleration, meaning hypoxia is happening within the baby. Now, this mom is coming at term. So here you can take measures drastic enough to save the life of the baby. So which ones would be it? Cesarean section, do a fetal blood sampling, induce labor, wait for normal delivery, or forceps delivery as early as possible. They have given you no information about the stage of labor she's in. It's just rupture of membranes. So the best option is that you do a cesarean. Very good. Very good. Now, if they have given you option here, oh, she is 9 centimeters dilated, head is at +2, what would be your option? Very good, Dr. Mia. We will do forceps delivery to make sure that we get the baby out as early as possible. Very good. So the correct answer in this situation is cesarean. All right, let me just I will explain it to you. It was a primary gravida mother who came at term with rupture of membranes, Dr. Sapphire. So, and her liquor was meconium stained. You did a CTG, it was late decelerations. Late decelerations mean the baby is in hypoxic distress. They haven't given you any information about what part of labor that is. So what is your next best step? Next best step is that you make sure do you get the baby out as early as possible. The only way for that is cesarean section. We do cesarean section, right? If they have given you information, for example, I was talking about how the answer will change if they have given you information about the stage of labor. For example, if her Bishop score was like 9, she was 9 centimeter dilated, head was at +2, and she was contracting very rapidly. And what would you do in that case? In that case, when you think that baby can have a spontaneous vaginal delivery, then you can expedite the delivery. How you can expedite? Number one, you can augment the delivery with oxytocin. Number two, you do forceps delivery. You take the forceps and you bring the baby out as early as possible. Because the immediate concern is we need to get the baby out because this baby might require resuscitation as well, as it was in distress. Okay? So, meconium state liquor, meconium stained amniotic fluid, thick meconium, yes. You do maternal assessment. You perform abdominal examination to see whether the baby is in breech position or not. And you do vaginal examination if clinically indicated to see whether there are cord prolapse or not. Then you do fetal assessment by fetal heart rate using auscultation or CTG, whatever is available. Initial management is you do continuous fluid fetal heart monitoring. You don't give antibiotic or don't offer augmentation if you think that there is no signs of infection. If you identified a probable cause that it's breech, then you can individualize the plan depending on the gestation period. For example, if it's term, then you can do a cesarean section. If you don't know it's breech and meconium stained liquor is there, you are suspecting intrauterine growth restriction, then you can do an ultrasound to assess that. Next step is that. What if on the CTG there is non-reassuring fetal heart rate? Yes, fetal heart abnormalities is there. Then what do? You expedite the birth. How do you expedite the birth? You can do either cesarean or forceps delivery, depending on how far the labor is. All right. Vaginal examination is not recommended more than 4 hours. So if you think that the mother is not going to progress in the labor, it's taking time, then you organize a cesarean section for them. You expedite the birth. And this newborn will definitely require resuscitation. So you make sure that you call the pediatric team on call as well. Okay. Too big. Is it clear, guys? Cesarean section is the answer. All right, we'll do one more question and then we'll take 5 minutes break, okay? Yes, this was essay health. 68-year-old woman came with 2 centimeter painful breast mass, which she noticed a week ago. What's the most common diagnosis in this age group? Breast cancer, mammary duct ectasia, fibroadenoma, fat necrosis, or fibroadenosis mammary dysplasia. So our postmenopausal age group female is coming with a breast lump. What is your most common diagnosis? And it's painful as well. Very good. So always remember a rule of thumb, guys. Postmenopausal female coming with a breast lump is breast cancer until proven otherwise. Okay. Mammary duct ectasia presents with a toothpaste-like discharge from the nipples. Fibroadenoma is not common in postmenopausal age. It's very common in young age group. And it's a hormone-dependent tumor which shrinks during the postmenopausal. Yes, breast cancer can present with painful lump as well. Fat necrosis has similar presentation to a breast cancer, but fat necrosis needs trauma history. Very good, Dr. Fayal and Dr. Ranjit. Fat necrosis needs a trauma or injury history. Fibroadenosis, mammary dysplasia, fibrocystic disease, it's also hormonal dependent. So in postmenopausal female, it's least likely to be the cause of a breast lump. Breast lump in a 68-year-old is or postmenopausal age is breast cancer until proven otherwise. Is it clear, guys? It's a short history. Maybe it had been there for a long time, but she noticed it 1 week ago. It doesn't have to be there for a long while for you to notice that this is a lump. She noticed it 1 week ago. We don't know how long it has been there. Okay. For fat necrosis necrosis means dying. Dying fat inside the breast tissue happens when there is a trauma or injury to the breast, blunt trauma or penetrating trauma. Okay. Fat necrosis is very difficult to differentiate from breast cancer because if you don't have a clear history of trauma, it's very difficult to say that fat necrosis is not breast cancer because they have similar clinical signs. It's a lump, it's painful as well, and sometimes their mammography looks the same as well. So we need to do biopsy to differentiate between the two. But breast cancer, it can be painful, it can be painless. Postmenopausal female, big red flag, doesn't have a trauma history. It's a rapid growth or slow growth, depending upon the type of tumor it is. It can cause dimpling of the skin. It can cause skin changes. So it presents in different way as well. Is it clear, guys? Yes, retraction of the nipple happens when the tumor is quite large and is attached to the underlying pectoral muscle or the overlying skin. It's late sign of breast cancer. Retraction of the nipple is when the tumor is quite large. It's late sign. Poudre d'orange is also one of the late signs of breast cancer when the lymphatic ducts are blocked and it becomes orange. So your answer is memory dysplasia or memory ectasia or fibrocystic disease. It's multiple lumps within the breast. It's very common in perimenopausal age or menstrual reproductive age. It regresses or increases with hormonal changes. So it becomes small and short and becomes hard when the menstruation is happening, and they becomes painless and small when the menstruation finishes. So these are the risk factors about breast cancer: advancing age, family history, early menarche, late menopause, high fat diet, late parity, obesity, short periods of breastfeeding, smoking, and previous benign breast disease. Alrighty. How about we take a 10 minutes break here? Just a 5 minutes break. And then we'll come back and finish this class. Okay, guys? All right, let's start again. Are you guys able to see the screen? All righty. Our next question is from psychiatry in young children. An 8-year-old boy came with his mother because he's very rude with his colleagues at school. He has a bare area of hair at the parietal area. Skin of the scalp is clean, and the hair remaining are in different lengths. What is your diagnosis? Trichotillomania, attention deficit hyperactivity disorder, depression, conduct disorder, or autism? So this 8-year-old boy is coming because he has some behavioral issues, and because of that, there is some hair missing from the scalp. What can it be? Very good. It's very easy question, to be very honest. This condition is called trichotillomania. Now, there are different terms used here. Let me give you just a brief information about the different terms used here. The first one which is used is called attention deficit hyperactivity disorder. Now, it's a very common disorder of the of young age group, and it's very prevalent in kids as well nowadays, especially. So, as the name indicates, they have attention deficiency and hyperactivity, and this kind of disorder needs to be diagnosed in patients when they are going to school or daycare, because it needs to be it needs two different social setups to observe the behavior of the children in order to diagnose that. So what kind of things they have? So from the attention perspective, they can have issues staying focused on tasks given to them. They have difficulty listening. They can have difficulty about keeping track of things, so they lose things quite easily. And they have difficulty organizing with organizing activities and tasks as well. From the hyperactivity perspective, they are very fidgety. They run or climb when it's quite inappropriate, so impulsive behavior. They are unable to sit quietly, and they have trouble waiting for their turn as well. So this is what basic meaning of attention deficit hyperactivity disorder. Depression is also a very common term that is used in in young adults as well. Not in 8-year-old unless there is massive trauma in their life, but it can present in teenagers with symptoms of low energy, feeling sad or hopeless, thoughts of suicide, irritability, changes in eating behavior, sleep changes, loss of interest in activities, and difficulty concentrating or making decisions. So that's how depression manifests in young adults and children as well. Similar things, but in different pattern they can happen. The other term they're using is called conduct disorder. Now, as the name indicate, it has problem with the conduct or behavior of the person. And it's basically someone who is criminal in a young age. So I always remember conduct disorders like criminals in making, because they have aggression towards people and animals. They destroy the properties. Have deceitfulness. They are involved in stealing and theft. They don't have any regard for rules and regulations. They lack remorse or empathy, and they are quite impulsive and reckless. So the way I remember conduct disorder is criminals in making. And every bad thing that you can find in the child that is criminal in making, just remember it as conduct disorder. Autism. Autism is not used as a single term. It is a broad spectrum now. It is used as autistic spectrum disorder. It's a whole term that has lots of levels under it. So these are the patients that have two kinds of problem. Number one, how they socialize, and number two, how they act. So they have difficulty socializing, they are having difficulty interacting with others, they prefer to be alone, they have narrow range of topics to interact about, they have difficulty using and interpreting body language, they can talk in monotonous tone or sing-song voices, they avoid eye contact, they have difficulty understanding perspective of different people, and they don't understand social cues, right? And how they act is that they have repetitive movements that is very calming to them, they prefer familiar routines and people around them, and they have the ability to be highly focused on their task. All right, so this is how the different terms mean. So trichotillomania is a disorder. Conduct is less than 18. Antisocial starts at 18. Conduct is less than 18, and antisocial is conduct disorder above 18. So you can study about trichotillomania over here, or I couldn't find a good source, but it's a type of obsessive compulsive disorder, hair pulling disorders, where you have this urge to pull the hair, and when you pull it, you feel a bit of reassurance. So why does it happen? It's an obsessive compulsive disorder. It can have environmental genetic factors. How do we treat it? We can treat it by cognitive behavioral therapies and some medications like antidepressant or anti-anxiety medications as well. Clear, guys? Any question regarding any of the terms we have used here? So your answer is trichotillomania. Any question, guys? All right. Next one is another psychiatric question. A mother came with her 7-year-old girl because she never had friends and children in school, and the children in school mock her always. But she never gives any reaction. She is developing very normally and had no language problem, but she has very restricted system of life and plays with her dolls only. What is the diagnosis? Autistic spectrum disorder, Asperger, ADHD, depression, or oppositional defiant? Very good. So we just talked about how autistic spectrum disorder presents, and this girl is having behavior problems and social problems exhibited under the autistic spectrum disorder. So our answer here is autistic spectrum disorder. Very good. Asperger syndrome is an obsolete term, and it's one of the things that come under autistic spectrum disorder. This is not a isolated syndrome anymore. It's not used in an isolated term. It comes under autistic spectrum disorder. And it's an obsolete term. We don't use the word Asperger syndrome anymore. It is either on the spectrum or not. Autistic spectrum doesn't have the developmental delay. They are all developed very normally. They just have language problem, social problem, and behavior problem. That has nothing to do with the development. Oppositional defiant disorder is a kind of disorder in which the children have problems with authority figure. For example, parents, teachers, they're very cool with their colleagues, but they have problems and defiant behavior against authority figures in their life, which is parents, teachers, police officers, etc., etc. Any age less than 18 is oppositional defiant disorder. All right, so your answer is autistic spectrum. I haven't discussed in detail about autistic spectrum because we have talked in the previous question, and I have explained very clearly about the signs and symptoms that can happen under the autistic spectrum disorder. All righty. Next question, guys. 70-year-old man, so very elderly gentleman, is coming with tiredness, fatigue, muscle pain all over the back. All over, sorry, myalgias are all over, and he's also complaining of back pain. So these are the symptoms. He had a complete blood count and perifilm film done, and there were Rolex cells. What is your diagnosis? Chronic lymphoid leukemia, acute myeloid leukemia, multiple myeloma, Paget disease, or chronic myeloid leukemia. So these Rolex cells, let me just show you guys. Rolex, what's the spelling? Roulous cells. These Rolex cells, they are aggregation of, these Rolex cells, these are aggregation of red blood cells, and they are particularly common in which disease, guys? Very good. They are particularly common in multiple myeloma. Let me show you guys how they look like on peripheral blood film. So this is how it looks like. Can you see the stacks of cells on top of each other? This is called Rolex cells. All right, and they're very common in multiple myeloma on the peripheral blood film. Plus, if you are confused and don't know information about what is Rolex cells and why they are present, always remember that Rolex cells become when there is increase in very good certain proteins, which is plasma protein in the body, or immunoglobulins in the body associated with plasma proteins or plasma cells. So plasma cell cancer is called multiple myeloma. All right. So if you have, yes, they do, especially in your hematology questions, they will show you pictures of peripheral blood film. And it will not be a difficult one. It will be very similar to the ones I have shown you. It's very easy to pick up. So Rolex cells is pathognomonic in diseases that have abnormal quantities of immunoglobulin fibrinogen, which is particularly present in multiple myeloma. If you don't know how to rule out other options, just pay attention to your question. 70-year-old man came with tiredness and fatigue and myalgia, back pain as well. Bone pain, especially back pain, is very common in multiple myelomas. Yes, fever, night sweats, myalgia is common in CLL, AML, Paget, or CML. But back pain, very common with Rolex cells. Always think about multiple myelomas. All right, let me show you about multiple myelomas and how we can differentiate it from leukemias as well. Are you guys able to see the screen on this one? So we all know that multiple myeloma, lymphoma, leukemias, they all start in bone marrows, but in all of these cancers of the blood, they have different cells that are affected. For example, in multiple myeloma, plasma cells are affected. These are the white cells that make antibodies to fight the cells. And myeloma cancer cells take over. Your body can't fight the infection. So once your plasma cells in your bone marrow is affected, your bones become very prone to pain. And myeloma cancer cells replace the bone marrow, right? And it decreases the immunity in the body. So most of the time, on the top of the prodromal symptoms, they can cause lots of presentation in the hospital with repeated chest infections as well. And you will notice that these patients will have high calcium level in their blood because of the osteolytic property of or eating away of the bone. And these cells, because there is abnormal plasma cells, abnormal immunoglobulin formation, these immunoglobulins can't get filtered from the kidneys, and hence your kidneys get damaged as well. Lymphoma starts in lymph node. They present with lymphadenopathy in the body. All right. Leukemia starts in your blood and bone marrow. You can't fight the infection, so you will present with symptoms of anemia, thrombocytopenia, and leukopenia. Is it easy to remember now, guys? All right. All of them will have these prodromal symptoms, right? Bone pain, confusion, constipation, extreme thirst. But most of the time in multiple myeloma, bone pain will be more prominent, and confusion, constipation, extreme thirst, fatigue, these are the symptoms of hypercalcemia as well. No appetite, weakness or numbness, weight loss you can't explain is the prodromal symptom of um, cancer. Lymphoma can also make you tired, but its prodromal symptoms are lymphadenopathy along with fever, night sweats, shortness of breath, cough, or itchy skin because of there is a reaction that happens when you take a bath, and it can cause histamine to be released in the body that can cause high itching in the body in lymphoma. Leukemia symptoms differ, but they are associated with anemia, um, lymphopenia, and thrombocytopenia. Is it clear, guys? How you can differentiate between these cancers now? Alrighty. Any question from the previous one, guys? So this is how you differentiate. You kind of just remember the basic things about, the basic things that you shouldn't forget when you're talking about hematological cancers like multiple myeloma, lymphoma, or leukemias. All right. Lesson 18. What is keywords to choose best answer in case of leukemia topic? Sorry, I don't understand your question, Dr. Samrat. What keywords are you talking about? All right. Let's move on to the next question. 68-year-old man, so an elderly gentleman, coming with frequent flank pain and painless hematuria. So they have flank pain and painless hematuria. They haven't mentioned what sort of microscopic or macroscopic, but there is flank pain and hematuria in a 68-year-old. What is the next best step? CT abdomen, ultrasound abdomen, cystoscopy after IVP, urine culture, or renal biopsy? Alrighty, let's have a look. Primary care presentation with hematuria. You have done history and examination to exclude non-urological causes, which is UTI or transient benign cause. What do? We repeat microscopy, which is microscopy. Flank pain with hematuria, we do urine microscopy and culture. If there is microscopic hematuria and there is macroscopic hematuria. If there is macroscopic hematuria, certainly you do CT IVP or renal tract ultrasonography to rule out any carcinomas. Similarly, if you have hematuria, the next best step is to do urine microscopy and culture. Can anyone tell me why we are doing this as a next step instead of CT IVP? As our answer is urine culture. Why am I choosing this? Even if it's a next best option. Very good, because most common cause of frequent flank pain with the painless hematuria is UTI, even in the elderly population. The next cause is urological cancers. Okay, So here you want to rule out infection first because it's the most common cause. If it is microscopic or macroscopic hematuria mentioned in the question, then you should go for CT abdomen if they said macroscopic hematuria. CT IVP. Intravenous pyelography. This is from RACGP. So if your urine microscopy culture is negative, you can do CT IVP or ultrasonography to rule out if there is any cancers or not. No, it doesn't take a lot of time. We do need imaging if your urine dipstick or culture is negative. It doesn't take a lot of time. It takes 2 days, hardly 48 hours for your urine culture to come back. It doesn't take lots of time. They haven't mentioned it's a microscopic hematuria or macroscopic hematuria. If they mentioned it's a hematuria that can be seen with naked eye, go for imaging because that will be the next best step. But if they haven't mentioned, then you will treat it as microscopic hematuria, painless with flank pain. Try to rule out UTI first because if this is the most common cause of the hematuria in adult population. Yes, 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 Dr. Param. That is absolutely right. All righty. Yes, if they say sample of urine was red, then CT is next step. Very good. It's a common sense thing that you try to do. All right. Next question, guys. A truck driver, 68 years, have on and off abdominal pain and bloating for the last 3 months. Sometimes he has diarrhea, sometimes he has constipation. He had colonoscopy since 1 year and it was normal. What do you want to do next as a best step? Colonoscopy, stool culture, abdominal ultrasound, sigmoidoscopy, or CBC? Next best step. What information stool culture is going to give you when a patient is having sometimes diarrhea and sometimes constipation with no fever? It's a 68-year-old that has altered bowel habits for the last 3 months. What is the next best step you want to do? Very good. We want to rule out colorectal cancer or diverticulosis. How would you do that? Diverticulosis can be present in all of the colon. It doesn't have to do sigmoidoscopy. So we will do coloscopy. Very good. Stool culture would be more appropriate if he had consistent diarrhea, right? If it was consistent diarrhea, then you would be worried about, oh, what is going on with the stool or what is happening with the gut products. You will do fecal PCR for viral bacteria and protozoans, right? But this is a 68-year-old that has on and off abdominal pain, bloating, and altered bowel habits, that diarrhea mixed with constipation, had a colonoscopy 1 year back, but still having red flags that require further investigation to rule out colorectal cancer. So we will repeat colonoscopy. Is it clear, guys? Doing a complete blood count will not show us anything. Right-sided colorectal cancer will cause iron deficiency anemia. Left-sided colorectal cancer will cause altered bowel habits and abdominal pain or tenesmus. So we need to do colonoscopy. You could have done fecal occult blood test in this patient. That would have given you some idea about ruling out cancer. But even if fecal occult blood test is positive or negative, you still have red flags in this scenario that gives you benefit of the doubt that you need to rule out colorectal cancer in this patient. Is this clear, guys? Okay. So your answer is sigmoidoscopy will only be up to sigmoid. It will not go up to the whole colon. So right-sided colorectal cancer most of the time present with altered bowel habits, abdominal pain, and iron deficiency anemia. Iron deficiency anemia will cause tiredness and stuff. Whereas left-sided will cause more obstructive features like prominent obstructive features, diarrhea alternating constipation, tenesmus, and difficulty in defecating. Yes. If fecal occult blood test was the option, then next step would be that, but best step will always be colonoscopy. We use fecal occult blood test for screening, and if we have high risk in the patient, even with the negative fecal occult blood test, you can go towards colonoscopy, like in our patient. These things. All right. They give you idea about screening. So screening we do about risk stratification, but if someone is symptomatic, then you can go straight towards colonoscopy. This is just a screening guideline. All right. It's very important for you guys to remember about different screening guidelines because they are asked in exams frequently, and especially cervical cancer, colorectal cancer, breast cancer. These are frequently asked in exams. So yes, from Red Book. I would recommend you guys to please emphasize on that. Yes, they do. All right. Any question, guys? So screening is done for general population with risk factors, and diagnostic or therapeutic investigations are done for symptomatic patients. All right, let's go towards next question. 78-year-old woman was fine, but 1 year she became more forgetful and not herself. She is dirty and careless with her clothes. She has resting tremors. Now came with neighbors because she shouts and yells about snakes crawling on the floor everywhere. So forgetful and not herself, becoming dirty and careless, these are all the signs of dementia. Very good. On top of having dementia, she has resting tremors plus visual and auditory hallucinations. So dementia with some signs of Parkinson disease and hallucinations is called Lewy body dementia. Very good. Now there are different types of dementia as mentioned in this question. Alzheimer's, Parkinson disease, schizophrenia is not a type of dementia, and senile dementia. Senile dementia is the kind of dementia associated with age. Alzheimer is dementia that happens in young age and is mostly associated with behavior and executive functioning. Parkinson disease has dementia, but it has other features as well, like resting tremors. They have rigidity, they have gait problems, and they have a reduced arm swing, bradykinesia. So these are the things that happen: vocal symptoms, dystonia, GI issues, mental and behavioral issues, and dementia. So these are the symptoms in Parkinson's disease that happens along with dementia. But if you have resting tremor-like features, dementia symptoms, plus visual disturbance, hallucinations, then it's called Lewy body dementia. It's a particular type of dementia. Schizophrenia is psychotic disease. It's a risk factor for dementia, but it's not a dementia disease. It's a psychosis. All right. So answer is Lewy body dementia. You can study from JM about that, and there is also very good explanation given in RSEGP as well, which is Royal College of Physician and Surgeon, Royal College of General Practitioner. So if you have a look over here, these are your different types of dementia: Alzheimer, vascular, frontotemporal, and Lewy body. Let's go towards the clinical context. I'll have a information about different types. Okay. Alzheimer, gradual decline in cognitive, especially ability to store new memories. Vascular dementia is slowing of the mental process. And there's scattered changes among the cognitive functions. Lewy body dementia, it affects the visuospatial and attention. That's why it can present with fluctuating confusion, visual hallucination, Parkinsonism, and rapid eye movement, sleep behaviors. Frontotemporal dementia is associated with personality and executive function and language. So it presents with behavior, language, and personality changes. All right. Any question, guys? Okay, let's move on. 34-year-old woman has her pap smear. Pap smear is not a term which is used nowadays. We use cervical screening test. And it shows there is a low SIL or a CIN, cervical carcinoma in situ at grade 1. Her last pap smear was 2 years ago and it was normal. What is the next best step we do? Repeat pap smear in 1 year, do colposcopy, do cone biopsy, refer to gynecologist and repeat pap smear. So pap smear is not a term that is used anymore. We use CST, which is cervical screening test. All right, as I said before, you need to know about the cervical cancer screening test so that you can give answer based on that. Have a look at this. Cervical screening test consists of 2 things in which we test HPV partial genotyping and liquid-based cytology. So when you do partial genotyping and no human papillomavirus is detected, we do routine 5-yearly screening. 5-yearly cervical screening test is done from the age of 25. If you do human papilloma screening and you've detected papillomavirus, but it's not 16 and 18, you do liquid reflux liquid-based cytology. If it is negative or shows low SIL, then you repeat the cervical screening test again in 12 months. Again, if it is the same virus which is detected and you do liquids-based cytology and it again shows low SIL, then you repeat it again for 12 months. If it's consistent in 2 screenings done 12 months apart, then you refer the patient for colposcopic assessment by the gynecologist. But if it is human papillomavirus 16 and 18 which is detected and doesn't matter what is the result of low liquid-based cytology, or if you have HPV detected, which is not 16 and 18, but your cytology shows it's a high SIL, then you have to refer the patient for liquid-based cytology. Oh, sorry, colposcopic assessment. So you have a patient who had her cervical smear test and it showed low SIL. What is your next best step? You will repeat it after 1 year. Very good. So you need to remember this whole flow chart in order to answer question. And I will tell you guys one thing, in your exam, you will have at least 3 to 4 questions coming from cervical screening test. At least, on the very least, 3 to 4 questions will come from this chart alone. Okay, so it's a very, very important chart. Just remember that if you have genotyping done, you need to follow it by a leukocyte-based cytology. If you have low SIL, then you need to repeat the testing again in 12 months. If it's again low SIL, then you have to repeat it again in 12 months. If it is consistently present, then you have to refer to the gynecologist. If it's a high SIL or if it is HPV 16 and 18, then you need to refer to colposcopic assessment. Pretty straightforward. If it is unsatisfactory, you repeat it again in 6 to 12 weeks. Clear, guys? All right. Next question. 58-year-old man, 40 years of smoking, and how much? 40 packs per day. He had a myocardial infarction last year and he stopped smoking then. He's now coming with exertional dyspnea, orthopnea, basal lung crackles, a dull area over the middle lobe of the right lung, and ankle edema bilaterally. What is your diagnosis? Congestive heart failure, chronic obstructive pulmonary disease with congestive heart failure, chronic obstructive pulmonary disease with col pulmonale, and irrelevant options. Very good. So we have established this is congestive heart failure. But what kind of heart failure this patient is having? If it is left-sided or right-sided heart failure? Very good, right-sided heart failure. Now, any patient who has chronic obstructive pulmonary disease with right-sided heart failure, what do we call it? Col pulmonale. Very good. Congestive heart failure associated with chronic obstructive pulmonary disease, right-sided dominant, is called col pulmonale. Very good, guys. Any confusion in this question, guys? It's pretty straightforward. When you have chronic obstructive pulmonary disease, it causes right heart strain, which leads to congestive heart failure. Most common congestive heart failure with COPD. Do you guys want? Basal lung crackles can be present in the chronic obstructive pulmonary disease. If you have bilateral pitting edema, then you should always think about right-sided heart failure. It doesn't happen in left-sided heart failure. Congestive heart failure can have various signs. It can cause exertional dyspnea, orthopnea, PND with edema, JVP raised, lung crackles. So they have various signs and symptoms. Let me just turn it off. They have given you history that he has been smoking cigarettes for 40 years. 40 years cigarette smoking. I do agree with you. It can be myocardial infarction, but 1 year ago he had myocardial infarction. But most consistent is the cigarette smoking. Orthopnea, dyspnea is not a feature of left ventricular failure. It's a feature of congestive heart failure. We can't say it's because of the left-sided heart failure or right-sided heart failure. It's congestive heart failure symptom. All righty. In this one, you can have a look about the management of the chronic obstructive pulmonary disease. I'll just show you guys just for reference. So this is therapeutic guidelines of Australia as well. It's quite commonly used as well. So have a look about what do we do in management of the chronic obstructive pulmonary disease, okay? Cigarette smoke doesn't always cause COPD. It does, Dr. Asif. Cigarette smoking for 40 years, 40 pack a day, definitely causes COPD. They will always have some level of chronic obstructive changes in their lungs. No way a 40-year smoking history with 40 cigarettes a day will have perfect lungs. The answer is chronic obstructive pulmonary disease with cor pulmonale. Okay, 50-year-old heavy alcoholic man. You can just type it in the Google. 50-year-old heavy alcoholic man came with ascites, enlarged liver 4 centimeter below costal margin. His abdomen is quite tender and his temperature is 39. Blood pressure is 100 by 60. Which of the following is the best treatment for the current problem? IV metronidazole and amoxicillin, IV cefotexime, paracentesis, oral amoxiclave, or IV albumin. So 50-year-old is a heavy alcoholic, is having ascites and enlarged liver, which means they're having cirrhotic liver disease, right? But abdomen is quite tender and is febrile. So tender abdomen in a patient who has ascites and cirrhotic liver disease is called spontaneous bacterial peritonitis. Very good, guys. So for treatment of spontaneous bacterial peritonitis, what is the antibiotic of choice? Very good. Not metronidazole. What do we give? Yes, very good. The empirical antibiotic of choice is cephalosporins. So cefotexime. We don't do paracentesis unless we control the blood pressure, temperature. Once before starting, you can do for diagnostic purposes, but it can cause spread of the infections. So start the antibiotic and then you can do paracentesis once the infection is resolved. IV albumin can be given when you're doing paracentesis to support the blood pressure because blood pressure is low as well. Very good. For spontaneous bacterial peritonitis, let me just open up this. What did I do? There you go. Sorry about that. It's very common with patients who have ascites, presents with fever, abdominal pain, tenderness, worsening encephalopathy, or renal failure. Investigation, diagnostic is you do a tap and there are 250 to 500 neutrophils per millimeter of cube, okay? Organism most commonly is E. coli, Streptococcus pneumoniae, and Enterococcus as well. Management is you give cephalosporins. So ceftriaxone or cefotexime you can give, or if they are resistant or not responding, you can change based on infectious disease consultation to ticagrelin clavulanate, or you can change if the patient is allergic to these, you can change the patient to cotrimoxazole or norfloxacin, and also give IV albumin if there is a blood pressure problem as well. This is prophylactic treatment to prevent spontaneous bacterial peritonitis as well. Clear, guys? So third generation cephalosporin is your antibiotic of choice in spontaneous bacterial peritonitis. All right, next question. 32-year-old woman came in her second pregnancy asking about what to do now as she had postpartum psychosis in her last pregnancy. So this patient is pregnant and now coming in her second pregnancy. And because in the first pregnancy, she had postpartum psychosis, what would you do? Review her in late pregnancy, start prophylactic dose of antidepressants, start her on antipsychotics now, do abortion as she's not allowed to get pregnant, start antipsychotics after the delivery. All right, let me show this to you guys so that you can have a look. So this is postpartum psychosis. Very good guideline about that. Okay, if the patient is at high risk, what can be done to prevent it? Let your psychiatrist and GP know you want to get pregnant before starting to try for a baby. You can discuss with them any medication you are recently taking so that they can change to antipsychotic that doesn't cause congenital abnormalities in the baby. They can advise you about how to stay well before the pregnancy, and you have to inform them as soon as you're pregnant. If you're already pregnant, it's important that everyone in your care knows about the mental illness you have in the past. And they all need to know that you have a high risk of postpartum psychosis so that they can increase the risk and care and support you need. And they should also help make a care plan. All right. What sort of care plan needs to be done? They need to be, for example, they need to have an early referral to the children and safety and family services, and they need early reviews in the pregnancy and late reviews in the pregnancy as well to see if they are developing symptoms or not. Doesn't mean that every patient with a history of psychosis should be started on antipsychotics. Is it clear, guys? Now try to answer the question. What will you do? Review her in late pregnancy, start prophylactic antidepressants, now start the antipsychotics, or start antipsychotics after delivery, or she is not allowed to get pregnant anymore. We will review her because if she is not having any sign and symptoms of psychosis and she is doing well, then we don't need to start the antipsychotics. If we think that her behavior is changing, she's developing signs and symptoms of psychosis, or she is near to psychotic episode, then we can start antipsychotics. We don't have to wait till delivery to start it. Is it clear, guys? All right. So your answer is review her in the late pregnancy. Next question. 52-year-old menopausal woman since 12 months came with vaginal bleeding after 24 hours of having intercourse. Her last pap smear was normal. What is the most probable diagnosis in her age? Cancer of endometrium, cancer of cervix, vaginal atrophy, or cervical polyp? Postmenopausal female, no problems, just acute onset of vaginal bleeding after 24 hours of having intercourse. What's the most common cause of diagnosis? Because her pap smear was normal is very good, vaginal atrophy. Most common cause of bleeding after intercourse in a postmenopausal female is vaginal atrophy. Very good, guys. Endometrial cancer can present with bleeding per vagina despite or irrespective of intercourse history. They will have bleeding per vagina, and it doesn't have to be followed by an intercourse history. Okay. So if they are having random episodes of vaginal bleeding, then you have a high suspicion, oh, it could be cancer of endometrium. Her last pap smear was normal, so less likely to be a cancer of the cervical cancer. And cervical cancer is most common not in the postmenopausal group, but in the reproductive age group. Okay. Cervical polyp could be there, but less likely to be present in the postmenopausal. It's also very common in the reproductive age group. Clear, guys? Most common cause of postcoital bleeding in menopause is vaginal atrophy, cervical polyps, cervicitis, ectropion. And these are the least common: cervical intraepithelial lesion or carcinoma. All right. Clear, guys? Any question? All righty. Next question. A diabetic 65-year-old woman noticed an ulcer on her foot for 7 days. She came to hospital and you admitted her. Surgical debridement was done and ulcer was then 1 centimeter and it was oozing a clear fluid. What do you want to do next? Give her antibiotics, oral, give her IV antibiotics, do an MRI to rule out osteomyelitis, do dressing and checking of the wound every day, or do wound toilet with iodine. So a diabetic person came with a diabetic ulcer, and then you admitted her and you removed the ulceration and debridement and the yucky tissue around it, right? It's a clear wound now with the clear fluid coming from it. So what would you do? You will just dress the wound. Because if it was a dirty wound, or if it was still cellulitic and if it was oozing purulent discharge, what would you do then? You would then give antibiotics. Very good. So diabetic foot ulcer, if there is a clear ulcer with the good margins and oozing a clear fluid after debridement, you just dress it and check the wound every day to make sure it's healing well. We don't toilet the wound with iodine because it will delay healing. MRI is done if you have a high suspicion of osteomyelitis, and MRI is not the first investigation we do. We first do X-ray. So MRI would be inappropriate here. If the wound was oozing purulent discharge, we will give oral antibiotic. If the female was having fever on top of the purulent discharge, then what would you give? Oral or IV? Very good. Your answer will change to IV antibiotic then. So your answer is dressing and checking the wound every day. It's very well written in John Murtagh in Diabetes. Yes, IV due to sepsis. Yes. Fever is a systemic sign of sepsis. So purulent discharge with fever, then you should definitely give IV antibiotics instead of oral antibiotics. Clear, guys? Any question? All right. Next one. A mother came with her 3-year-old child. He can't eat because of small oral ulcers in his mouth. He also has ulcers in his fingers and toes. His temperature is borderline febrile. What is the causative organism? HSV, Coxsackie virus A, adenovirus, group B, beta hemolytic streptococci, or coronavirus. Very common disease in children when they have oral in mouth, hand and foot. What is it called? Hand, foot, mouth disease. Very good. And what is the causative agent for hand, foot, mouth disease? It's Coxsackie virus A. Very good. Very, very common disease in children. Very good. So Coxsackie virus is the answer. Coxsackie virus A16 is the most common cause of this. All right. Clear, guys? Any question? I'll just show you what hand, foot, mouth disease looks like. Let me show you guys the image of it. This is how it looks like. Blisters in mouth, blisters in hands, and rashes on the feet. This is how it looks like, hand, foot, mouth disease. It's caused by Coxsackie virus A16. Next question. Alrighty. 30-year-old female has type 1 diabetes since 20 years, so long time. Is coming with painful foot. She had an X-ray done, and there was osteopenia and decreased joint space in the tarsal joints. Tarsal joints, just in the tarsal joints. What is the diagnosis? Osteoarthritis, neuropathic joint, rheumatoid arthritis, osteoporosis, or SLE. It's a 30-year-old. All right, let's rule it out. For systemic lupus erythematosus, you need to have at least 9 categories out of 11 to diagnose, none of which are present. So less likely to be the cause. Osteoporosis, they have already mentioned they have osteopenia. Osteoporosis, less likely to be present in a 30-year-old. Very common in in elderly population or patients with malnutrition. Nothing of that sort is mentioned over here. Rheumatoid arthritis is a disease of small joints of hand and feet. They have just mentioned about the tarsal joints. That's about it. And it's a symmetrical disease that involves all the small joints of hands and feet. And there is osteopenia, but is the most common, let me just the most common cause of rheumatoid arthritis feature, let me just open up quickly, X-ray findings. All right, so there is soft tissue swelling, erosion of the joint space narrowing, and subluxations. So osteopenia less likely to be present, but can present in rheumatoid arthritis. Most likely to be present is there is erosion of the joints, and there is joint space narrowing and subluxation, which is not present in this. Osteoarthritis can present with osteopenia and decreased joint space, but it doesn't happen in 30-year-old. Osteoarthritis is the disease of the elderly. So what is the answer? Type 1 diabetic patient, more chance for them to develop a neuropathic joint disease. Okay, very common to happen in the lower limb, especially in tarsal joints. Is it clear, guys? All righty. So if you know about the features of other diseases, it's very easy to come towards your answer. If you know that, oh, osteoarthritis and osteoporosis, these are diseases of the malnutritive patients or elderly patients, less likely to be in 30-year-old. The only two options you have, rheumatoid arthritis and SLE. SLE needs at least 9 out of 11 criteria to be filled before defining its joint disease, right? Whereas rheumatoid arthritis, rheumatoid arthritis at least need symmetrical involvement of the joints, right? But in neuropathic joint or Charcot joint, you have osteoporosis, osteopenia, decreased joint space in the tarsal joints because of autoimmune disease like type 1 diabetes. It's Dr. Rabia, Dr. Shabir. Do we start antibiotic therapy, spontaneous bacterial peritonitis after checking Cliff's SOFA score? Cliff's SOFA score is basically used for acute liver failure on top of the chronic liver failure, acute on chronic liver failure. It could be because of spontaneous bacterial peritonitis. So if you do have a febrile patient with acute liver failure on top of the chronic liver failure, worsening renal function, uremic hepatic encephalopathy, and febrile illness, we do start antibiotic therapy. Is it clear, guys? So your answer is neuropathic. Last question of, this is how neuropathic joint presents. There is osteopenia, osteoporosis, and then deformation of the joint, ankylosis basically. Last question. So the only clue they have given you is that it's type 1 diabetic. In type 1 diabetic, neuropathic joint are more common rather than, especially if it's a young patient. If they have mentioned elderly patient, I would definitely recommend you to go for osteoarthritis rather than neuropathic joint. Because more common with the features they have given about the description of the joint disease. Last question of the day, everyone. A female patient had a lock operation in lithotomy position. Which muscle could be affected? Flexor hallucis longus, flexor hallucis brevis, extensor hallucis longus, biceps femoris, or soleus? Dr. Maria, lithotomy position, biceps is not present in lower limb. So lithotomy position damages which kind of nerve? Which nerve is damaged in lithotomy position? Common peroneal nerve. Which muscle is innervated by common peroneal nerve? Very good. Extensor hallucis longus is innervated by common peroneal nerve. So your answer is C, and patient will present with which symptom? Slapping gait of foot drop. Very good. Alrighty. Thank you so much, everyone. I hope you had a wonderful session. This is how we do the classes in our course. And we do take 2 hours time. And so we take time with each and every one of these questions and try to make sure that we give you appropriate reference for the answer as well. The other thing is sometimes because we are also learning and students as well, so we don't have answer to everything. And whenever you have problems or we have conflict in the questions, we do try to facilitate the answers by consulting with each other or with our colleagues as well. All right. I hope you have a wonderful session, and I hope we can see you in our course. I'm looking forward to working with you guys and try to make sure that we equip with you with enough information to help you pass this exam. It's quite possible exam. It's just that you need a good knowledge and tips and tricks about how to solve the MCQs to help with that. All right. Thank you so much, everyone, and you have a wonderful night.